Are you curious about what schizophrenia is? If so, then make sure you keep watching. In regards to schizophrenia, there is a lot to cover, so I've decided to break this down into two parts. So this is part one of the schizophrenia lecture. Let's get started. What is the clinical picture of schizophrenia and when does it usually start? So the onset is usually between 15 to 25 years of age. The prodromal phase, usually there will be milder symptoms and they can often develop months or years prior to the onset of the disorder. Some manifestations that can clue you in that something is off is that grades start slipping, they withdraw socially, they display a sense of suspiciousness, or there's disorganization in speech. And usually females have a more favorable outcome than males if they are diagnosed with schizophrenia. The DSM-5 criteria for schizophrenia, which is the Diagnostic Statistics Manuals, says that 2 or more of the following must be present and at least 1 during a 1-month period or less. So they have to have delusions, hallucinations, disorganized speech, and they may or may not be disorganized or have catatonic behavior or have negative symptoms. The 4 main symptoms of schizophrenia are positive symptoms, negative symptoms, affective symptoms, and cognitive symptoms. And we'll talk about positive and negative in a little bit, but affect is the mask that the person portrays. So what is their facial expression like? And cognitive symptoms has to do with thinking and thought. Epidemiology. So it occurs in childhood about 1 in 40,000. It is more frequent in males. Onset in males is between 15 to 25, and onset in males is associated with poorer functioning and outcomes. Onset in women can be between 25 and 35, and women tend to have a better prognosis and have less structural changes in the brain as opposed to males. There is a lot of comorbidity in regards to schizophrenia. Comorbidity means that there's overlap in conditions. So there tends to be a lot of substance abuse, and a lot of times it's kind of like which came first, the chicken or the egg. So are they using the substances in order to quiet the voices, in order to help them with their anxiety, in order to help them with their paranoia? Or is it the fact that they went on a cocaine binge and they altered their neurotransmitters and then they ended up developing, they had a psychotic break and they ended up developing schizophrenia? So it can go either way. The most common substances that are abused in this population is alcohol and marijuana. And substance abuse is associated with more non-adherence, relapse, incarceration, homelessness, violence, suicide, and poorer outcomes. So there's a big trend towards legalizing marijuana and all that, and if they're using it for medicinal purposes and because this person has cancer and they need it in order to stimulate their appetite, or if we're talking about the oil, that's all fine and dandy. But we can't forget either that we can't pretend like marijuana is this benign drug that doesn't cause anything. So again, alcohol is legal and yet it can lead to devastating outcomes in people that abuse it. Same thing with marijuana. It is not benign and it is associated with all of these things which I just mentioned. So more non-adherence, relapse, incarceration, homelessness. Anxiety and depression and suicide co-occur. If you think about it, it's common sense, right? If someone is constantly hearing voices, they just want the voices to stop. Oftentimes you'll see them covering their ears and things like that. They do tend to attempt suicide more often, and it's 5 times higher than the general population. Physical illness is also higher because a lot of them will, let's say, not be compliant with, if they're have diabetes or high blood pressure, will not be compliant with meds, or they can't afford to be compliant. And not only that, as you're going to learn in a little bit, second generation antipsychotics are associated with metabolic syndrome. So they predispose these individuals to gain weight, to increase their blood sugar, to gain weight, what we call it here in their belly, central adiposity. And they often do die more than 20 years prematurely. A lot of that has to do with the fact that they're homeless, they don't have access to care, non-adherence. So many of them will develop polydipsia, which is excessive thirst, and then that causes hyponatremia, which is low sodium levels, and then there's a sudden increase in psychotic symptoms such as delirium. What is responsible for schizophrenia? Well, there are hypotheses, and the most popular theory is the fact that it's multifactorial. So we can't just blame it on one thing, but 80% of the risk factor for schizophrenia comes from genetic and epigenetic factors. So there is a very, very strong genetic component to developing schizophrenia. Risk factors, neurobiological. There is a theory, the dopamine theory, that these individuals have an excess of dopamine, and that is what is responsible for their psychotic symptoms. And then things such as amphetamines and cocaine can induce psychosis or bring about the disorder. Now, will it happen in everyone? No, but people that are predisposed, once again, you try cocaine, and then it creates this imbalance in the brain, and next thing you know, they've developed schizophrenia. Amphetamines and cocaine increase as well as release dopamine, and also they initially will increase levels of norepinephrine and serotonin. Other neurochemical hypotheses include serotonin, glutamate, and GABA, but realistically, the one that you will most likely be tested on will be dopamine, and that's what the current drugs target, is dopamine receptors, and we will be learning about that in a little bit. In schizophrenia, there have also seen that there are brain structure abnormalities, and there's decreased activity associated with negative symptoms, but then also they've seen that perhaps ventricles are enlarged or things of that sort. So actual brain structure abnormalities with schizophrenia, not only imbalance in neurotransmitters. There's been studies that show that there's reduced volume and changes in the shape of the hippocampus. As you can see here, this is a ventricle, and this is ventricular enlargement in the affected brain. So ventricular enlargement. There also can be reduced gray matter in the temporal and frontal lobes, and we know that the frontal lobe is responsible for decision making. There can be neuronal growth in some areas, and there's reduced connectivity in brain regions. Now, in regards to what causes schizophrenia, there's also a psychological environmental component. 98% of individuals with schizophrenia have had some previous exposure to some kind of trauma, such as violence, abuse, and neglect. So again, it's kind of almost the perfect storm. We have this individual that has a predisposition, and unfortunately, they experience some kind of life-altering trauma, and that pushes them over the edge, and then they develop these psychotic symptoms. Now, people who have experienced trauma, they're 4 times more likely to become an alcoholic, 4 times more likely to develop an STD, 4 times more likely to inject drugs, 3 times more likely to use antidepressant medication, 3 times more likely to experience depression. You see all these issues that come from trauma. 15 times more likely to commit suicide. 15. And this is why I always say that we cannot judge when people are addicts. We cannot judge because we don't know what they've gone through. We don't know what they've experienced that led them to put that needle in their arm, or that led them to pick up that bottle, or that led them to take their life. So people experience unimaginable things. And once again, we are never here to judge. We're here to be compassionate caretakers. Another interesting fact is the fact that prenatal stressors can also contribute to developing schizophrenia. So an infection during pregnancy, father older than 35 years of age, and being born in late winter or early spring. Why is that, you ask? Well, remember here, infection during pregnancy. We are more likely to get sick, whether it's with flu or any type of rhinovirus, more in the winter months and early spring. And that is the hypothesis as to why these individuals are more predisposed to develop schizophrenia. That was a super interesting fact. I at least find it interesting, but I'm a nerd, so. Also, psychological stressors, right? Stress increases cortisol levels, which impedes development of the hypothalamus. So stressful situations, I put here nursing school. You all know how stressful nursing school can be, or moving away from family. And once again, trauma, sexual abuse, social adversity, or psychological trauma, things like being bullied. Again, all these things have unimaginable circumstances. Do they affect everybody? Will everybody that experiences develop schizophrenia? No, but again, it can lead them to other things. Environmental stressors, so toxins such as tetrachloroethylene, which is found in dry cleaning, water pipes, and drinking water, have also been associated with schizophrenia, and urban areas that experience high crime. Family members ask the nurse about the relative's chance of a positive outcome after being diagnosed with schizophrenia. Which of the following information should the nurse provide the family? It's a select all that apply. So, is good premorbid functioning can predict a positive outcome? Early age of onset can predict a positive outcome. Being male can predict a positive outcome. An abrupt onset of symptoms can predict a positive outcome. Or a family history of schizophrenia is associated with a positive outcome. The right answer is good premorbid function can predict a positive outcome. So the healthier they are to start with, then the better they are to deal with this condition once they get it. And an abrupt onset of symptoms can predict a positive outcome. Sometimes they may have a psychotic break, but then they will bounce back and then they won't have any more symptoms. However, if it's a slow, insidious onset, especially early on, that is not associated with positive outcomes, and they are more likely to develop a more aggressive form of schizophrenia. Phases of schizophrenia. There's the prodromal phase, so there's mild changes in thinking and reality testing and mood, and it may appear a month to a year before a full-blown episode. Early intervention is best. Then you have the acute phase. That's where they're psychotic. So they have their psychotic episode. They may have negative symptoms, impaired judgment, and symptoms may vary from mild to severe. This is where in the acute stage they will be hospitalized or Baker acted. And then there's the stabilization stage, and the symptoms are stabilizing, maintenance or residual, the condition is stabilized and a new baseline is achieved. And then schizophrenia is chronic, like heart disease or diabetes, so they need to take their medications, and it doesn't just go away. This is where we get to discussing positive and negative symptoms of schizophrenia. So negative symptoms of schizophrenia is pretty much everything that starts with A. So alogia, no words. Avolition, no motivation to doing anything. Anhedonia, that's loss of interest or drive in doing things. Whereas the positive symptoms of schizophrenia, so as it says here, positive are additions to consciousness, whereas negative symptoms are a decrease in functionality. So with positive symptoms of schizophrenia, it's a spectrum. You have someone that is at a certain level of consciousness, and then there's an addition to it. So they also have hallucinations or delusions, and they may have disorganized speech or disorganized behavior. They may also have cognitive and affective symptoms, and cognitive is impairment in memory, attention, thinking, problem solving, and affective is emotions and their expressions. With reality testing, the person believes that the hallucinations or delusions are absolutely 100% real. They are not aware that these voices are within them and are not coming from an outside source. When they hear these hallucinations, that's important. They truly believe they are real. Once they're on meds and they're more stable, then perhaps you can reason with them and they realize, yes, I'm hearing the voices, but I know that the voices aren't real. But when they are completely delusional, which is a false fixed belief, they truly believe their thought process. For example, if they think they're the King of England and they're not, right? That's a delusion. It doesn't matter what you say to them, how much you argue till you're blue in the face, which you shouldn't be arguing with them, but they are convinced that they're the King of England. It doesn't matter what you tell them. It doesn't matter if you show them a birth certificate. It doesn't matter. They truly believe they are the King of England. These are a few of the delusions. There can be persecutory, which means I feel like someone is trying to chase me. Referential, I see a billboard sign, I think it's talking about me. Grandiose, again, I'm the Queen of England. Erotomanic, everyone is in love with me. This celebrity, I'll say a celebrity, I don't even know, is Jason Momoa, right? Jason Momoa is in love with me, and he is so in love with me, and he's just with his wife as a friend, right? Nihilistic is just a view that everything is awful, that nothing's going to work out. It's a really pessimistic view. Somatic is, I feel, I have cancer, right? And no matter how many CT scans we do on someone that show that this person does not have cancer, he has cancer, he thinks he has cancer, he's going to go to Mexico and he's going to gets by some chemotherapy because we don't want to treat him in the United States. We want to kill him, right? And delusions of control. I don't want to get my insulin injected because you're going to inject a little bug in me that's going to control me, and you're going to have full control of my movements and my thoughts. That's a delusion of control. Positive symptoms in schizophrenia, there are alterations in speech. There can be associative looseness. So I need to get a Band-Aid. My friend was talking about AIDS. Friends talk about French fries, but how can you trust the French? So you see that it's associated, but it's loosely associated. Word salad makes absolutely no sense. It's a bunch of words thrown in together that are bizarre. So color, horse, highlighter, boat, right? They're not saying anything in their mind. They think they're saying a sentence. Clang associations is basically rhyming, right? Click, clack, cluck. Neologisms is making up words. And echolalia is parrot-like repetition. Echo, right? Lalia. So the nurse says, hey, we need to go outside. And the patient's like, hey, we need to go outside. Stop that, stop that. Go to your room, go to your room. That's echolalia. Echolalia is basically an attempt to identify with the person speaking. They don't know where they end and the other person begins. Circumstantiality is offering superfluous details, and they eventually get to the point though. I feel like we all know someone who just does that normal in everyday life. Tangentiality is wandering off topic and never reaching the point. Cognitive retardation is a cognitive slowing. There's delay in responding to questions or finishing thoughts. Mistakenly, a lot what I see in practice is that people will call this thought blocking when someone has a delay in responding, but that's actually cognitive retardation, not so much thought blocking. But again, you're going to see it in practice. People all the time are going to be like, oh, she's thought blocking, and that's what they're referring to, that the person isn't responding. True thought blocking, though, is they start talking and they just stop. Pressured speech is urgent or intense speech, and they feel like they have to talk and they're going to get it all out, and they're just talking a million miles a minute. And flight of ideas is moving rapidly from one thought to the next. So, I'm hungry. Does my dog need to go for a walk? I wonder what the weather will be tomorrow. What is the purpose of life? I should learn to play canasta. My mom should lose some weight. Wait, I forgot to pick up my kids from school. So, it's all over the place. Things are just flying one idea to another. Symbolic speech is demons are sticking needles in me, when in reality he's experiencing sharp pain that is symbolized by the needles. Thought blocking is stopping a thought mid-sentence. Thought insertion, a belief that someone else inserted a thought into their brain. The ones that are highlighted, though, are the ones that you're most likely going to be tested on. And thought deletion is a belief that thoughts have been taken or are missing. NCLEX time! A client's diagnosed with schizophrenia states, look, color, hate me, get, trash, yes, no. Which is an appropriate charting entry to describe this client's statement? And the correct answer is word salad, right? It's not a command hallucination. They're not making up words, which is neologisms. It's not a delusion of control, so the correct answer is 4. That wasn't too tough. Magical thinking. So I had a client on the unit, and he was in a corner, and he was jumping up and down, and he was going like this, and he had bizarre facial expressions, and he was laughing and going like this and like this. And I asked him, like, so-and-so, what are you doing? And he's like, I'm doing my rain dance. Like, to him it was super obvious, and I'm like, okay, tell me more about that rain dance. He's like, well, when I dance like this, it rains. So to him it was super obvious, right? He does his little rain dance, and it rains that day, right? And of course, because it's Florida and it's unpredictable, it did rain that day. So what did that do? It only reinforced the fact that his rain dance works. Despite what I had said, I understand that you think that your rain dance makes it rain. I find that's doubtful, right? Expressing doubt is a form of therapeutic communication, but it rained that day, so he wasn't having it. He truly thought that he caused the rain. And then they may have paranoia, which is an irrational fear that is mild to profound, right? Another client one day, I just had walked on the unit, and I go sit down, and he finds me, and he's like, who sent you? Is it the CIA? And then there's that other organization, NSA, I can't remember them. He's like, was it the CIA, FBI, NSA? I'm not even sure if that's the right one, but he was asking me all these questions because he thought I was after him. That's the paranoia, irrational fear. Now, with schizophrenia, a lot of times people will get confused between what is a hallucination and what is a delusion, right? what is a hallucination? A hallucination has to do with your senses, right? We have 5 senses. So you either hear it, you see it, you smell it, you taste it, or you feel it. That's it. If it doesn't have to do with the senses, then it is not a hallucination. Command hallucinations can be very dangerous. Command hallucinations directs a person to take action. Command hallucinations are very dangerous. They direct a person to take action. For example, someone is hearing a voice and they think it's a voice from God, and the voice is telling them that they need to kill their mom because their mom is possessed by a demon. So in their mind, they truly believe that they're hearing a command from God, and the voice is so convincing that they will go harm their mother because, again, so command hallucinations, very, very dangerous. You will always want to ask your client if they are hearing command hallucinations, and if yes, what are the voices telling them, and does the patient recognize the voice as not real? It's less dangerous if you ask the patient if they're hearing command hallucinations, such as kill yourself, and I say, do you recognize that the voice is not real? Yes, I know that it's not real even though I'm hearing it, so I'm not going to act on it. Okay, good. Can the patient resist the commands? No, I can't. The voice is from God and it's telling me I need to kill my mother and I love her, but I know that this is what needs to be done. We're in serious danger there. This patient needs to be Baker acted, right? So you always want to assess for, are they hearing commands? If yes, can they recognize them as not real? And if not, can they resist the commands? Alterations in behavior. They may have catatonia, they may have waxy flexibility, they may have posturing, motor retardation, motor agitation. What is waxy flexibility? Think of a doll, right? Think of a wax doll or even a Barbie doll. Waxy flexibility, they love to ask this on exams. Pretend I'm the client, a nurse comes up to me, she lifts my arm up to take my blood pressure. I'm going to put it this way so you get the point. The nurse walks away, my arm stays up here. That's waxy flexibility, right? I just hold, if someone moves my hand anyway, if someone were to put me like this and I have waxy flexibility, I stay like this and I just stay like this for hours. That's waxy flexibility. The nurse, the intervention is move my arm back down. Posturing is when I, the client, put myself in a bizarre position. So if I go like this on the unit and I stay like this for 30 minutes, that's posturing. That's me putting myself in a bizarre position. They do it. It's part of their mental disorder that's going on. They're not doing it to be funny. So again, we don't make fun of them. Nothing. The intervention is we are going to inform the physician. We're going to talk to the physician about maybe altering medication or discussing what we can do because again, this is a sign of their psychosis, of their schizophrenia. They may have motor retardation or motor agitation. Echopraxia is where, again, they echo the movement of someone else. So if someone else is going like this, someone else will go like that. I had a client that was doing echopraxia with me. And if I would smile, she would smile. But it was really bizarre. She was almost like a delayed reaction. So I would smile and she would go. Almost like sloth-like repetition. You know how sloths are so slow? That's how she would mimic me. And if I did any movement, she would do it too, and she'd be like. So, very interesting. Positive and negative symptoms of schizophrenia, once again, they may have hallucinations, delusions, disorganized thought, and nonsensical speech, bizarre behaviors. Negative symptoms of schizophrenia, they may have a flat affect, so they show no emotion, reduced social interaction, anhedonia, no feeling of enjoyment, avolition, no motivation, allosia, speaking less, and catatonia, moving less. This is a spectrum of the difference between affects, right? Here's a normal affect if you find out you win the lottery. This is a constricted affect, so less emotion, and this is a blunted affect, even less emotion. If we were on a spectrum, the most severe, it goes from normal, constricted, blunted, and then flat would be here, which is absolutely no emotion. Now, you can also have bizarre affects. You can have flat, which is immobile or expressionless, inappropriate, laughing in response to tragedy. And there was a scene in Gotham where the child that plays the Joker, he's talking about the death of his mother, and all of a sudden he just starts laughing maniacally, and he's like, "Ah!" And it turns out he's the one that killed his mother. So again, that is inappropriate, and then bizarre would be just laughing. You're talking to someone asks to go to the bathroom, and they're like, can I go to the bathroom? Or I need to go to my room. And then they're just like, it's hard to explain, but when you see it, you know it. It's just very bizarre. Like the client that was doing the rain dance, his facial expressions, they were just very bizarre. They're odd, illogical, or inappropriate. Cognitive symptoms that they may have is concrete thinking, so they're unable to think abstractly. So if you tell them something like, one of my students one day told them, man, school is costing me an arm and a leg. And he was like, really? How much does that go for? How much do you sell your leg for? Which leg are you going to sell? So again, he couldn't grasp the fact that she was speaking figuratively and not literally. They may have impaired memory, impaired information processing, difficulty with reasoning and setting priorities, and an inability to realize that they're ill due to their illness. In regards to assessment guidelines, always make sure that a full medical workup has been completed. For example, if someone has really high ammonia levels, that can induce psychotic symptoms. But that's something that can be helped if you give them some lactulose and some medication. It can decrease their ammonia levels. You want to assess for substance abuse or alcohol disorders, complete a mental status examination, and again, assess for hallucinations. Do not imply that the perceptions are real. So what do you hear versus what are the voices saying? And ask about the hallucinations. I put old card because it's an acronym. When did they start? What's their onset? Location, not so much, but duration, characteristics. What are associated symptoms? What are relieving factors? What are temporal factors? Thank you so much for watching. Make sure you hit the like and subscribe button.